Have you ever been to the emergency department? Have you ever wondered what a trip to the emergency room would be like? Or if you have been to the ER, what do you wish you would have known ahead of time? I'm Grace Trafton of The Better Part. Stay tuned and hear some answers from our guest. We're fortunate to have as our guest today Dr. Karen Molander, a physician who has been practicing emergency department medicine for several years. Her goal is to help prepare our community for the next emergency room visit. Welcome, Dr. Molander.
Thank you.
First, tell us a little bit about your background as a medical doctor.
Well, I decided to become a doctor when I was about 10 years old due to a very sick mother. To become a physician, you have to finish 4 years of college. I did 4 years of medical school in Chicago, and then was wooed out here to the lovely California coast and did a 3-year residency at Stanford, and I stayed.
You're a very wise person. So what attracted you to work in the emergency department, and what do you find most rewarding about working there?
The incredible variety is probably the most rewarding. Every day is different. It is completely unpredictable. They have a tendency to call emergency medicine physicians adrenaline junkies, just because it's that unpredictability that we tend to enjoy. We may have someone come in with a heart attack or a stroke. We may deliver a baby. We may have to suture a laceration closed, all before 9 a.m. So I think that was probably the most tremendous draw. And it is nice having set hours, so even though I may be working a night shift, I know I will be done after 8 hours. So that's also a very nice part of it.
So it just keeps you on your toes, and there's never a dull moment.
Definitely. Well, there's some days that are slower than others, but we don't use the Q word in the emergency department because that usually forebodes a very busy shift if someone says it's quiet.
So what type of training does an emergency medicine physician have?
So we do the 4 years of medical school, and then you have to specialize in emergency medicine as a residency. You are taught how to put breathing tubes in people who are not breathing. You are taught CPR. You're taught how to do advanced life support to someone who's critical. You are trained to deliver babies. You're trained to take care of ankle sprains, broken bones, abdominal pain, chest pain, so a wide variety of issues that you face in the emergency department.
So you have quite a bit of additional training then, don't you?
During residency, we have to we rotate through many different specialties. So we'll rotate through internal medicine, we'll rotate through surgery, we'll rotate through ear, nose, and throat, so that we learn a little bit more about each of these specialties. The goal as an emergency medicine physician is to stabilize that patient and know when you need to ask for that specialist to come in. And that's the whole goal that we have.
Now, when do I know that it's a real emergency?
So the easiest way to think about it is whether it's life or limb threatening. That's kind of a short answer, but typically if you are having acute severe chest pain, if you are not able to move a portion of your body, if you're having bleeding that you can't control, if you've fallen and you can't get up, those are all definitely emergencies.
What should I be bringing to the ER if I'm capable of bringing things?
So the easiest thing is to think about being prepared before the emergency happens. So when I'm working in the emergency department, something that's much more valuable to me than this stethoscope is your bag of medications and a piece of paper inside of it with your name, your medications, your allergies, and most importantly, an emergency contact. Because oftentimes people don't realize, they think, oh, I'll go to the hospital that I always go to. Mm-hmm. Sometimes those hospitals are closed to ambulance traffic. So you may
Oh.
end up at a different hospital that does not have your information on their electronic health record. I think one of the other challenges is that people don't realize that some hospitals have different electronic health records that do not communicate effectively. So it is very difficult sometimes to get information. For example, during an overnight shift, when they don't have someone available in medical records to help you access that information. So if you can bring your medications with and a contact name, those are the most valuable things.
Now, since we don't know when we'll be going to the emergency department, should we be keeping our medications and that information in a bag like you've shown
I do.
us?
I recommend that you keep everything with you in one bag and a simple file card where you can write all that information down. You know, your name, your medications, your allergies, your medical history, and that emergency contact. And if you can put down the name of your primary care doctor and their phone number, that's also quite helpful.
Okay, so we should just keep that on hand at all times.
And our emergency medicine personnel are smart enough when they come out and the EMT shows up at your house, they usually do a quick scan to see, does this person have this information? And you can ask them, please bring that with you. Sometimes they'll leave it and just write the names of the medications, which is not as valuable for me. So I do appreciate it when they bring it in.
Okay, that's really good to know. Is the waiting time dependent on the severity of the patient's condition?
Very much so. There's also other variables that come into play. How busy the emergency department is. Is there a portion of the emergency department that can deal with urgent care style of issues? So if you come in with ankle sprain, you're likely to be seen after the person who's having a heart attack.
Right.
But if they have an urgent care section of the ED, you may get zipped back quite quickly. So it's very variable. The national average for an emergency department stay varies depending upon what your complaint is.
And what is the difference between an urgent care or walk-in clinic and an ER?
So typically, an urgent care clinic either is self-standing, it can be affiliated with a hospital, or it can be affiliated with a larger organization. For example, in our community, Palo Alto Medical Foundation or Kaiser has urgent care centers as well. Stanford also has self-standing clinics as well. And there's even urgent care clinics within CVS pharmacy. Typically, an emergency department is affiliated with a hospital, especially in our community. There are rare instances of self-standing emergency departments in Texas, for example. But with an urgent care clinic, you're usually able to get an appointment. You're usually seen more quickly. They may not cover certain types of insurance, so you have to make sure that your insurance is covered. And they're not obligated to see you if you don't have that insurance. In the emergency department, we treat everybody regardless of ability to pay. And we're open 24 hours a day. And the biggest challenge is the wait, because it can be a lot longer in an emergency department than in an urgent care center. There's also a difference between what type of physician or care provider may see you. In an urgent care center, you could be seen by an internal medicine doctor, a pediatrician, a family practitioner, a nurse practitioner, a physician assistant. Typically in the emergency department, the physicians there are trained and what we call boarded in emergency medicine. And you can also have additional mid-level providers there, such as a physician assistant or a nurse practitioner.
So why aren't there more urgent care clinics?
I suspect part of it is because of the considerable amount of money it takes to open up an office. You don't have a set of patients that are guaranteed to return to you, that assign themselves to you. And you sometimes can see a 3 to 6 month delay in payment for that visit. So you have to have quite a bit of money invested in order to open an urgent care clinic. And that's probably why we see most of them affiliated with Stanford, with CVS Pharmacy, with Palo Alto Medical Foundation, with Kaiser, as it's much easier to deal with the ebb and flow of how busy the urgent care center is and how they're able to staff it.
Now, is every emergency department alike?
Oh, absolutely not. We have, in our community, we are blessed with very many different types of emergency departments. We have emergency departments that are community-based. We also have emergency departments that are affiliated with universities. And we have some emergency departments that specialize in management of stroke, where the hospital itself also specializes in stroke. And the same holds true for management of an acute heart attack, what we call a myocardial infarction. There's emergency procedures that can be done only at certain hospitals. There are some hospitals in the area that have pediatric emergency departments within them, and there's also some emergency departments in the area that have psychiatric components to the emergency department.
But not all emergency departments have these features?
They don't all have that capability. We treat everyone who walks through the door, but for example, if someone is presenting with a psychiatric emergency, it can be much more challenging to try and find a bed to get that patient admitted to the hospital. So we have to look for a hospital that has inpatient psychiatric beds that can care for that patient.
So the patient will be transferred to the appropriate hospital.
Exactly.
Now, who is likely to care for me if I arrive in the emergency department?
I guess the easiest way to describe it is to walk through your visit to the emergency department. If you're well enough to have someone drive you to the emergency department, the first person that will typically greet you when you walk through the door of the emergency department is either a volunteer who serves as a greeter or the triage nurse. And the triage nurse will tell you to give you the chief complaint or the reason why you're coming to the emergency department. They'll try and gather a little bit more information about your medical history, and typically we'll have the help of an emergency department tech to get a set of what we call vital signs, that being heart rate, blood pressure, temperature, for example.
What exactly does the word triage mean?
Triage is the way that she is trying, or he is trying to figure out how ill are you? How severe is your presentation? Is this someone who needs to be rushed back to one of our critical care beds immediately? Or is this someone who can be allowed to wait in the waiting room until there is another less critical bed available?
And how long should I expect to stay in the ED?
That depends upon what your chief complaint is, whether you have lab work done, whether you're being admitted to the hospital, whether you have any studies performed in radiology, like an ultrasound, a CAT scan, an X-ray, or if, for example, they need to call a consultant to get their opinion as to what should happen. Typically, in the United States, if someone is coming in for a minor injury in the emergency department, the nationwide average for your stay in the ED is 2 hours.
Only 2 hours?
That's if it's a minor complaint, and it varies considerably amongst facilities. If you are presenting with a complaint that will require admission to the hospital, that typically can take 5 hours for you to be admitted to the hospital. So that is a longer stay. And for example, if you're being admitted with a psychiatric complaint, that can be a much longer stay. That can be 9 hours. If you're at a facility that doesn't have psychiatric beds, for example, we have to work on arranging transfer. So it can be a much longer stay.
Oh, I see. So it really depends on the condition.
Very much so.
And not that we always have a choice, but is there a good time, quotation marks, to visit the ED?
So the emergency department, the best way to approach it is to be prepared, like a good Girl Scout. Bring a book with you because it can vary widely. We have a much higher volume of patients during the winter months because typically there's a lot more cases of flu and pneumonia. Typically Sundays and Mondays are quite busy, and part of that is related to the fact that the hospital is busier on a Monday. They're performing a lot more surgeries, so there can be a considerable delay in when an emergency department patient is admitted to a bed because they're also admitting surgical patients to beds as well.
So the availability of beds is really an important factor.
That can be a rate-limiting step, definitely.
What can I do to make the process go a little bit more smoothly?
I think one of the key things to think about is to make sure that you bring someone with you. Because you may be thinking you're wide awake and you're able to answer the questions clearly, but if you've broken a bone and they give you a pain medication that makes you super sleepy and slurring, you're not going to be able to remember what the doctor or the nurse said. And you want that person who's with you to be able to write down the names of the people who are taking care of you, write down the names of the medications they're giving you, and also make sure that you've got a clear example of what the next steps are for the management of your care.
So what if there isn't anybody available for me to bring?
That is a challenge, but it happens to us all the time. And again, that's part of the reason why I recommend having that emergency contact phone number so that we can update family members or friends and let them know that you're at the emergency department and what the plan will be for you.
Now, when should I be calling an ambulance?
The easiest way to think about that is whether it's something, again, that's life or limb threatening. If you're having symptoms of a heart attack, which can vary considerably amongst people, chest pressure, chest pain, pain radiating into the arm, pain radiating up into the jaw, shortness of breath, sudden feeling of severe fatigue, all can be signs of a heart attack. That would be an indication to call 911 because, for example, in this area, you may be diverted to a different hospital that specializes in management of acute heart attack if they see worrisome signs on the EKG that the paramedic is likely to perform right at your bedside.
Now, if that is the case, and my regular hospital is not does not specialize in heart attacks, in heart conditions, would they take me to some other hospital instead?
Exactly. They'll take you to a hospital that specializes in management of heart attacks, which is why I was talking about how important it was to have that list of medications and the contact people. Now, there's also other indications for calling 911. For example, if someone's having signs of a stroke, the easiest way to think about it is think fast. The F standing for face, A for arm, can you put both your arms up? And then S, speech, so talking to someone. And then T, we use the term time. And that's because, again, you're going to be diverted to a specialized hospital so that they can manage if they suspect signs of an acute stroke. 911 also gets the benefit of having a paramedic show up your door who's trained in this, who can go through additional testing to see, are you having signs of a stroke? They can check your blood pressure, your heart rate. They can also check your oxygen level, and they can check your blood sugar level because a low blood sugar sometimes can mimic a stroke.
I see.
There's other reasons to call 911. If you have fallen on the ground and you can't get up, it's not safe to try and get yourself up on your own. And the other issue is don't wait. Because if you're laying on the ground for an extended period of time, that can cause damage to bones, it can cause damage to muscle. Time is of the issue. And also, if you're having bleeding that you can't control, direct pressure over the site of the bleeding is not resolving it. And don't do peeking. You know, stay with that hand down for 5 minutes. That's another reason to call 911.
Okay, so it's really best to call 911 when in doubt rather than get a neighbor or family member to drive you to the emergency department.
The one benefit is if you're dealing with one of those unusual presentations for a heart attack or stroke, you're being sent to a facility that specializes in it. It's nice to have family with you again, so it's good to make that second phone call so that they're coming with you. And the other thing is, when the paramedics show up, they may determine, okay, you're not showing signs of a heart attack or a stroke. It's okay for you to go with your family member, or we can have your family come with you to the hospital. So that's another important reason for calling 911.
Now, what exactly is a patient advocate?
I feel very strongly that patient advocates should be sung from the highest mountain. The easiest way to think about it is a patient advocate is someone who's there for you. It can be a family member, it can be a friend, it can be a neighbor. But it's someone who is there to hear what the nurse is saying, what the physician is saying, what any other support staff are saying when they're involved in the care of the patient. And I think one of the things that's really challenging is there are so many people involved in the care of a patient in the emergency department. So many bodies running in and out. And it's hard for you, the patient, who's dealing with an acute issue, to be able to say, wait a minute, who's that person and that person and that person? And it's easier for the patient advocate to say, hi, I'm Jane. I am so-and-so's friend, and I'd like to understand your role in the care of my friend. Because it's important for that advocate to be able to get that information for you. After one dose of morphine, when you have a broken bone,
Right.
you don't usually remember a fair amount of the information that's conveyed.
Right, right. So if I don't have a family member or neighbor who can advocate for me, is there somebody at the hospital who can play that role?
We do, at most of our community hospitals, have social workers or volunteers available. We are working on a patient advocacy system, but it's in its infancy. And a lot of the community hospitals in the area are trying to involve folks who have been patients at our hospital to help come back to clinicians and say, you know, this is much better if you sit down and you make eye contact with the patient. And it's not formalized at the large majority of hospitals, but there is a really big upsurge in this popularity. I think we will be seeing more of this coming soon.
And this is for all hospitals?
All hospitals in the area. I think some are probably further along the path than others. The other thing to consider also is if you don't speak English, we are required by law to find a translator for you.
Oh.
And the different ways that we will go about that is sometimes it's a physical being, someone there at the hospital who has been given permission to serve as an interpreter, who may work in the laboratory or be a nurse up on the third floor. Or, for example, they also have phone translating services and they have video translating services at some hospitals.
Now, in this area where we live, there are so many different languages. So how would a hospital know which languages to have this service for? So
I work next to an airport, and it is very often that we have patients that come in with different languages. And usually we are able to discern the language that they speak by, typically the patient can say what their language is, and we can translate that one word and try and figure out what specialist. But the telephone interpreters and the video interpreters are phenomenal. There's a large range of languages that they speak that we're able to access, so we use speaker phones to communicate.
So you have this network of different interpreters.
Yeah.
Oh, wonderful.
Yes.
So, so I guess, you know, from what you've been telling us, it's really not easier for us to go by ourselves. We should.
I strongly recommend having someone with you. Now, on the other end of the spectrum, if you bring 20 people with you, it's not likely that we'll be able to fit all 20 people in the room. And it's also challenging as an emergency medicine physician to have to tell the same story to multiple different people.
Right.
Because it is so busy in the emergency department.
So you don't want a whole gang of people coming with you.
Probably not 20 people.
Right.
But, or you have one person serve as the leader of the group and say, I will talk to you about the progress, please update everybody else.
Now, do the emergency departments have separate areas for psychiatric patients or pediatric patients?
It varies from emergency department to emergency department. Sometimes we'll have informal areas designated as pediatrics or psychiatric. There are some facilities in our community that do have specific pediatric emergency departments, Lucille Packard, Stanford, for example. And there are some hospitals in the area that have separate locked wards for the most challenging psychiatric patients who are not able to control themselves. But we also tend to have psychiatric patients right next door to someone who's there with abdominal pain. So it can make for a very loud experience sometimes. So bringing some headphones and some good music sometimes is a good choice.
That's a very good advice. Well, thank you, Dr. Molander. You've given us some very, very good information. Thank you for being here today.
Appreciate your time. Thank you so much.
The Better Part is produced by volunteers, and absolutely no experience is required to join, so come check us out. Just leave a message at the Cupertino Senior Center. Thank you for being with us today. I hope you've gained some valuable information. And remember to also watch our programs on YouTube and Roku. See you next time. Bye-bye.